All right, let's talk. We're going to talk on the kid side first. So here's sort of a menu of the pediatric things that we're going to worry about: slip capital femoral epiphysis, leg calf perthes, the septic joint, toxic synovitis, sort of more of a teen, hip dysplasia, the little kiddies, small ones, where dislocations don't take a lot of force, and then the limping child. We're going to remind ourselves right up front that oftentimes across all ages, when someone complains of knee pain, particularly medial knee pain, and you look at the knee and there's nothing there, you got to think maybe it's the hip. So hip pain is referred to the knee quite frequently. And particularly in kids that don't quite know, the limping kid will say, it's my knee, and in fact what they mean is, it's my hip. Here's the ossification centers. This is obviously relevant when you're looking at x-rays of kids and how they develop. And so you have to sort of interpret a joint that's not fully developed with all the ossification centers done growing. What happens is these ossification centers don't really form and fill out until the musculature is beginning to pull on them and allows them to lay down more bone. In kids, there is, both at the knee and the hip, there is a vascular junction that is open. We think of the bone as not being in vascular continuity with the joint in adults, and it's true, it's not. In kids, there are vessels that traverse through the epiphysis and through the cartilage portion of the joint directly into the joint space. Why is this important? It's important because when a child gets osteomyelitis, it can extend into the joint. So they can have osteomyelitis and a septic knee, or osteomyelitis and a septic hip. As opposed to adults, they don't get both, they get one or the other because that vascular continuous channel has closed along with the physis closing. All right, now we'll go to neonatal congenital hip. This really is more of a clinic kind of thing. It's usually screened for very early by the pediatricians and stuff. It's not often become an emergency medicine problem, but sometimes it's missed or it wasn't done well and we see it. It's about 0.4% of all deliveries. It's girls greater than boys. Breech birth, because the kids in that crouch position for longer are associated with it, and obviously forces are applied at delivery. And the Barlow and Ortolani tests are the ones you want to look at, and we should have those here. So the Ortolani test, you flex the knee up, abduct the thigh, and as you bring the leg out into the frog leg position, the dislocated side will be restricted and you'll feel a click as it slips out posteriorly through the acetabulum. And the Barlow test is where you bring the knees up, and as you can see with the lower image, and you push down on the kneecap and it comes out posteriorly. These are usually done together. You do both tests. And then there's, I don't know if I have a picture here, a Galeazzi sign, but if you were to imagine that kid down on the bottom right, if you were to look at the knees when the kid's left knee drops lower, right, when that hip dislocates, one knee will be lower than the other. When you bring the kids up and you push down, the one that goes out will be lower. So if you were to look at the two kneecaps, one would be lower. That's Galeazzi's sign. The same guy that did the Galeazzi fracture also noted this in congenital hip dysplasia. All right, now, jumping up to sort of the limping child, and we're going to sort of look at this table. This table's actually kind of worth sort of having around. So in toddlers, you're mostly worried about infection, septic arthritis. They get some transient synovitis, but not often. And then osteomyelitis is very much in there. Trauma, it can be. It's often in that age group, you're talking about child abuse. And then congenital stuff is there, but only really in the youngest group. All right, you get a little older, the infectious stuff is there, trauma starts coming up in frequency, and occasionally you'll encounter a kid with juvenile rheumatoid arthritis, so-called Still's disease. That is not a subtle disease. Those are really sick kids, high white counts. You know, even if you don't recognize it as the primary presentation of Still's disease, alarm bells will be ringing all around letting you know, this kid's got something wrong with him, I need help. Adolescents, septic arthritis is still there, and GC comes up. Although gonorrhea doesn't particularly like the hip, it can get there. Gonorrhea tends to like the wrist and the knee more than the hip. And osteomyelitis still there. Trauma definitely coming on, and then you're also in the JRA group. And then finally you get into some of these degenerative things. You'll notice that in the adolescent group, slip calf femoral epiphysis is more the older group, leg calf perthes more the younger group. Having noted that, if you got a 10-year-old, they could have either, right? All right, let's look at leg calf perthes. So you can see that the one hip on this child is completely moth-eaten. But you should remember, and anytime you diagnose this, you should tell the parents, all right, the other hip looks okay, but remember, you have to lose a lot of bone density before the x-ray changes. That's why we always say with osteomyelitis, you got to lose 25% of your bone density before a lytic lesion from osteomyelitis shows up. So that good-looking hip could harbor some of what the bad-looking hip has. And we know that about 1 in 7 of these kids have bilateral disease. So you should, when you see this, you should tell a parent, we found this problem, your child's got a bad hip, they've got this avascular necrosis, leg calf perthes problem, and it might actually affect both hips. We're going to get a pediatric ortho specialist as well. This also can occur with sickle cell. There's some minor trauma history or in some of the cases. We don't really know if that's true, and causal, or true, and unrelated. So that's there. And again, pain referred to the knee. And there's that image again for you. You can see that left hip is moth-eaten. All right, slip capital femoral epiphysis. This is the older fat kid, right? So it's the overweight 14-year-old. This too can be bilateral, and the arrow is pointing to the ice cream cone, which is melting off. And there are a variety of lines you can look at to sort of do this. And here's a better image. It's the same one, just more isolated. You can see that the left side has slipped off. This too can be bilateral on occasion, and Klein's line is the line you're looking for. It's drawn along the superior border of the femoral neck, and Klein's line should contact the femoral head. It should go through the corner of it. If it misses the femoral head, it's slipped off towards the medial side. So here we see a normal one on the left. It's not a great image, but it's hitting the femoral head. And then the one on the right is just barely nicking the corner. It's missing it more than it's hitting it. So those are those. Now we go to septic hip. Clinical predictors, fever and white count. As you'd expect, this is a pretty substantial infection. The child usually will not bear weight, so they've gone from limping to I won't bear weight on it. SED rates and ESRs are up. And a negative SED rate and a negative ESR almost rules this disease out. The problem is that the positives don't tell you that it's a septic hip. It could be anything. Now, if not only the CRP and the ESR are positive, but they're super high, that points towards septic joint more than other things. Blood cultures are often negative. Ultrasound has become the diagnostic modality of choice, and the reason is this. If you do an ultrasound and there is a joint effusion, that's what the ultrasound is going to find, then the ultrasonographer is there to guide the tap so you can get to the juice and test it as well. MRI, if you're going to do an advanced imaging modality, oftentimes it'll come down to CT or MRI. CT is obviously a little bit more available, but if everything was equal and you could choose, for hip pathology across all age groups now, you would choose MRI. And the reason is that MRI is good for the occult hip fractures in the elderly lady from the nursing home, and it's also good in this setting because it will diagnose extra-articular pathology as well, or things like soft tissue problems, tumors, things that might be present. And so MRI has become the winner. Having noted that, if I couldn't get an MRI and I could get a CT, I would probably go to CT. All right, what are the organisms? And this is the typical pie chart and the joints and things that are there. And so in peds, most of times you have a septic hip joint, it's due to hematogenous spread. Having noted that, it's mostly staph. In adults, you got to worry about IVDA and post-surgical causes. And as I indicated, most are staph, but other things get involved depending on what the other risk factors are. And in sicklers, we worry about salmonella, and everyone always says, oh, that's because salmonella is an encapsulated organism, and that's why they get salmonella infections. There's one problem with that. Salmonella is not an encapsulated organism. So the fact that the sickler has asplenia is not why they get salmonella. That's why they get pneumococcal pneumonia, It's not why they get salmonella. The reason they get salmonella, osteomyelitis, and ergo sometimes a septic hip in kids is because salmonella grows particularly well on an iron-enriched growth media. And so as they break down their blood cells with their life of sickle cell, they deposit these heme and iron pigments in their bone and joint capsule, and so they've been turning their bones and joint capsule into ideal growth media for salmonella. That's why they get salmonella. This is a true emergency. With a kid or an adult who's got a staphylococcal infection or one of these other bacteria in their hip, what happens is that thing is going to eat their hip, eat their cartilage in a relatively rapid state. They're going to have a dysfunctional joint in short order. So it's really a time-dependent thing. You want to make the diagnosis, you want to get the antibiotics up, and in some cases they're going to take them to the operating room and wash the joint out. So this is a really important diagnosis. And you can see down here the clinical association of different organisms with different groups. You know, with neonates, you see the group B and the E. coli that they're going to pick up from crossing the birth canal. You're going to see some strep pneumonia in the first 2 years. We talked about the salmonella with the sickle cell, and some emerging pathogens that, quite frankly, I've never identified. It doesn't mean I haven't missed it, but I've never identified it. I like this slide a lot. Because when you see someone who's febrile with hip pain or with knee pain that you think is referred from the hip, there's a tendency to just focus on the hip and say, well, it's a septic arthritis, that's what I'm looking at. Or maybe it's osteomyelitis of the femur. I like this slide because it reminds you not to get locked in too fast. There are other things with fever, and there are big muscle groups and things that cross the joint that can fool you. And so appendicitis could fool you on a right hip. Discitis could fool you because it could be referred pain down the nerves. Sacroiliac infection could fool you because it seems like the hip, you can't really tell where it is, it's the pelvis. Pelvic abscesses. I've definitely seen PID in a younger woman that seeded their hip. So they both had PID and a septic hip. Iliopsoas abscess is another thing to consider. Even ticks can fool you in an older age group. We're talking about kids here. Hopefully we're not to the point where children have ticks, but in older groups, ticks can fool you. So I think this slide is just an important one in terms of your general thinking about a patient with a fever and what seems like hip, lower abdominal pain, to remember to keep your diagnostic thinking broad before you focus in solely on the musculoskeletal system. All right, toxic synovitis is really an irritable hip. There's nothing toxic about it, right? There's no bacteria. It's a misnomer, and it's called this irritable hip. They will have a sympathetic effusion, but it's believed that the primary problem is actually extra-articular. Ages 2 to 5, boys greater than girls. You'll see it up into the teen ages though. They frequently have a low-grade temp, 100.5, 101, that type of thing. For the world, when you see one of these, it looks like a septic hip. They won't bend their hip. It can be post-viral, post-strep. It gets better with NSAIDs, and all of the textbooks and much of the literature on this says you can go ahead and discharge them. The problem is that I face when I work these up, and I don't know how you guys feel about this, is I always am stuck. I feel like I have to rule out a septic hip. I am rarely confident enough naming something like this, especially when the stakes are so high with if it's actually an infection in the joint. So I'm usually find myself doing the ultrasound again to look for the septic hip, and then they say, well, there's no effusion in the joint. Now, it says there can be an effusion here. Usually when you see them acutely, they don't have the effusion yet. It's an extra-articular process. And then I'll stop. They also say you can send them home with NSAIDs. A lot of these kids have enough pain that they end up at least short-term admitted or OBS for a period of time. And they often end up getting recurrent labs, repeat CBC and SED rate and things because everyone's kind of worried still that it might be a septic hip. All right, avulsion fractures. Kids who have these big growth plates in their pelvis, they get avulsion fractures. And this extends up into teen years and sometimes into their 20s, depending on what kind of stupid things they're doing, like jumping off roofs and stuff like that. It's more men than women, and it's because the muscles in the younger men and boys are stronger, stronger than the growing bone, and they pull off these epiphyses. So the ischial tuberosity can do it in track, the iliac spine in soccer, the anterior superior iliac spine and ballet are most common. They might even have heard a pop. There might be a big bruise in the area, and this drawing really summarizes it. So the abdominal muscles can pull off the iliac crest. The ASIS is the sartorius. The inferior iliac spine is rectus femoris. We see that a lot in Los Angeles with soccer players, particularly when it rains. Someone goes to kick a soccer ball that weighs 6 pounds more than it should because it's a crappy ball that's soaked with rainwater, and they pull it off at the time they make contact. You'll see hamstrings on the ischial tuberosity. That's the person who jumped off a roof and sort of landed in a forced squatting position. Will do those. And sometimes a jumper will get the, someone doing a long jump or something will get their gluteal muscles pulling off their greater trochanter. Now those fractures, when you see them, oftentimes those avulsions, you'll need a comparison. Now the good news is with the pelvis, if you get an AP pelvis, it's an automatic comparison view, right? Shoppers, it's a blue light special. You get 2 for the price of 1. So you usually have that. A lot of times, because these injuries, they pop and they hurt, but the kid can still walk with these, right? So they come in 5, 6 days later. The parent brings them in because it still hurts. And that will really fool you, because when you x-ray these, when they have these fractures, the new bone growth, the callus formation that happens with these is unbelievably exuberant. They'll now have this big calcific mass that you'll be thinking is some bad tumor, like a rhabdomyosarcoma or something, because they really will get a tremendous amount of calcium and callus deposition during the healing phase. So don't be fooled by that. All right, adult hip anatomy. Sockets deeper, joint capsules stronger, tremendous weight being borne across it. This is a weight-bearing structure. It takes a lot of force to dislocate a hip. This is the most common mechanism, which is a kneecap into the dashboard, driving it out posteriorly. It'll be internally rotated and shortened. If you don't relocate it promptly, if you say, oh, well, we'll wait for the specialist to come, if you do that, all you're inviting to the table is avascular necrosis. They say there's a 1% incidence of avascular necrosis for every minute it's out of the joint. So if you're comfortable waiting an hour for your consultant, you just increase the chances of a dead hip by 50%. So you want to relocate these promptly. And here you see some images. There's oftentimes a fracture of the posterior column with these. Don't let that fracture convince you to not relocate it. People go, oh, it's a fracture dislocation, I can't relocate it. A little chip fracture off the posterior column is not a reason to wait. You should still put this hip in. And here you see some other images. That's that same image. And it looks like there's a posterior column fracture there, in fact, underneath the tip of that blue arrow. This is called the Whistler method right here, the over-under, which is a far preferable way to relocating this hip than the Alice method. The Alice method is also known as whack your head on the ceiling light in the exam room, fall off the gurney, hurt your back, and swear to yourself that I'll always let the consultant do it. So the Alice method is really primitive, archaic, and sometimes humorous. Over-under works much better. There's some other methods out there. What's not shown here, if you're going to do the over-under Whistler method, is the intact foot beneath the fulcrum. That left foot needs to be tucked right under the butt and held there, because that's what gives you the height to get the length on the other leg, to get it to come into place. You will always need some muscle relaxant with this. Versed usually is not enough. I personally prefer Brevitol, but you can use Propofol, you can use other things. And every once in a while, I see someone try and do this with ketamine, which is a bad idea, because ketamine doesn't give you muscle relaxation, right? Ketamine preserves motor tone. That's why you don't have to intubate people when you use ketamine. It preserves tone. So ketamine, not a good choice. Anterior hip dislocations are really rare. This is an anterior, this is actually a luxatio erecta of the hip that's shown with the leg pointing straight out. That's a very rare injury, less than 1%. And true anterior dislocations are less than 5%. And they'll be externally rotated and long. Neurovascular compression of the femoral nerve and artery can occur in these, whereas there's almost never a neurovascular problem with a posterior hip. but an anterior hip can cause them. Again, urgency exists to relocate them if there are these neurovascular issues. And there you go. Now, this is the one that's a special thing where you probably ought to be making a phone call before you do anything. The dislocated prosthetic hip is no big deal because there's no potential for avascular necrosis. They have a ball of titanium, not bone. But what could go wrong? The real thing you're worried about is if you're doing some force with the relocation here, you're worried that the round ball, that is the femoral head, the new fake femoral head, will catch on the corner of that cup and dislodge it. If you dislodge that cup, then the whole hip replacement has to be redone again. And so in this case, there's no risk of AVN. You can wait a little bit and you can talk to your orthopod and let them do it if they want. If they say go ahead and do it, you can say, all right, I just want to make sure you're okay with it. I don't want to dislodge that cup. I'll do my best not to. All right, hip fractures, really below, they come in a couple different ways. We're going to look at intertroch and subtroch. Pain management is often required for these. Lots of people are doing a 3-in-1 femoral nerve block. I like that femoral nerve block very well. You can do it ultrasound guided or straight up. It's pretty easy to do. Lots of times these patients are going to need a general workup with chest x-ray, EKG, and Foley. And the elderly patients who have these fractures are often coming to you from nursing homes. And you all know what that looks like, right? They bring some old lady they found on the floor of the nursing home. It's, you know, skilled nursing facility. Is there any bigger misnomer in medicine? I don't know. It's a toss-up, really, between skilled nursing facility and go lightly. Those are the two top nominees for the biggest misnomer in medicine. But in any event, you know, they come in and you go to take a history. Ma'am, my name's Dr. Mallon. What's happening? And they go, you're going, great. Review of systems unavailable. Or they do another thing, which I love. This has happened to me a couple times. You know, they bring the nursing patient and I go, hi, I'm Dr. Mallon. What's happening with you today? And they look at me, and the last one, they did this really cracked everyone. She looked at me. She looked at the nurse. She goes, who the fuck is he screaming at? And when you get to be 90, that's sort of irreverence. I think you've earned that right. What do we know about the older lady with the hip fracture? We know that the sooner you fix it and the sooner you mobilize her, the better she'll do. And so anything that delays her surgical repair is muy, muy bad for her. It puts her at risk for UTIs. It puts her at risk for pneumonia. It puts her at risk for PE. And so you should not admit these people to an orthopod. The orthopod is the cabinet maker. They will make the cabinet when it's time. But before the cabinet can be made, the anesthesiologist and the medical doctor will have to say, okay, make the cabinet, it looks safe. But because they have comorbidities, when you admit them to ortho, they try to take them to the OR and the anesthesiologist cancels the case. This has happened over and over again. And so it's become clear, and there are multiple papers demonstrating this, that when you're admitting the old lady with a hip fracture, they need a doctor. You should admit them to one, and then the doctor can call the cabinet maker to fix the hip when they're ready. There's not always a lot of trauma with these. They have osteoporosis. You want to make sure you're not dealing with a pathologic fracture, particularly if they have a, you know, something like breast cancer or one of those that tends to go to bone. The films, plain films, can be hard to interpret. And we know that the risk of an occult fracture, it's very consistent across the literature. It's about 4% of these old ladies who you get an AP pelvis on that you cannot see a fracture on that have one. That's pretty common. That's 1 in 25 of them have this occult fracture. So don't force them to stand up. If you don't see the fracture, but you think they have one based on it hurts in their hip, they can't bear weight, those types of things, then you move to advanced imaging. Again, as I said a few moments ago, we now know that if you could choose any advanced imaging, the advanced imaging you would choose would be an MRI. If it's not available, get the CT. CT, there was a recent study by Greg Hendy where they it's the first study that compared the CT and the MRI head-to-head in a little crossover mode. Great little study, not huge numbers in it, it's not the strongest science in the world, but it showed that MRI definitely picked up fractures that CT missed, but CT didn't pick up any fractures that MR missed. So MR won. MRI wins. These are for these fractures that are shown here, like number 1, where they can be very, very subtle. Once you get down to the fractures lines 2 and 3, these are going to be more obvious, generally speaking. There's more displacement. They're easier to identify. The cortical disruption is easier to see when you're following the cortical lines. So about 4%, they often won't walk, and you really don't want them to walk, because when it's non-displaced fracture, the repair is super easy, right? They make a little slit in the skin, and they go in there and they go like this. That's it. They drive 3 big long screws and leave it right where it is. But if that lady were perchance to have the fracture miss, stand up and snap it off, now they have to do a big open repair, which exposes them to much greater postoperative morbidity and mortality. So identifying these with the advanced imaging before it snaps off while it's non-displaced is really important for the long-term outcomes. And as soon as they drive those 3 screws in them and sew up the little incision, they're rehabbing her the next day. They're going to try and get her up and start her doing some toe touch weight bearing and things like that. So don't miss them, because the consequences of missing these fractures is they're going to snap off, and then it's a much harder surgical repair. Here's just sort of shows a little occult hip fracture algorithm that says go to MR or CT. And that's the message. I understand MR isn't always available, and if it isn't, CT's pretty darn good, but MR is a little bit better. It's certainly better for the soft tissue pathologies and extra-articular stuff. And here you see some MRs and just how subtle these can be. There's a plain film with an arrow showing you something that you were supposed to see. And you can see that's pretty subtle. Pretty subtle. And that's just typical on these old osteopenic ladies. Sometimes they have so much degenerative joint disease you can't see anything because there's all this degenerative joint fluff around covering it. This is one of my favorite diagnoses, meralgia paresthetica. It's a pinch of a pure sensory nerve going down your leg, right? The lateral femoral cutaneous nerve gets pinched. The lateral femoral cutaneous nerve comes out just below your anterior superior iliac spine over here. So if you palpate the anterior superior iliac spine and then you just inject underneath that area, pain be gone. It's like this burning lateral thigh pain, instantly gone. So use bupivacaine, because it's going to wear off eventually, but I'd like it to last as much as possible. And there are all kinds of reasons this happens: work belts, tight, springy pants. There's another paper that described it as young women of reproductive age with a rapid weight gain, which was about the most unflattering way to say pregnant that I've ever heard. But anyway, pregnancy is associated with this because in the 3rd trimester in particularly, they got those springy pants and they got the things and they're walking around like this and it's putting pressure there. Greater trochanteric bursitis, a so-called hip pointer. This will often happen if you fall and land directly on a hip. You'll get a little burst and you'll fill it with hemorrhage and it'll hurt for a while. I had these when I was a kid playing indoor soccer and it hurt for like months. But they can also happen from inflammatory causes as well. They're most common in that regard with the inflammatory causes in middle-aged women. Treatment is avoid the movements that hurt. NSAIDs, you might do a steroid injection. I don't inject these myself. As I told you, I'm not a wild injector of things all over the body. I'll inject shoulders. I'll do a Finkelstein's, a positive Finkelstein's with dequervain stenosynovitis. I'll inject those. But I'm not big on fishing around the hip. Thank you very much.